Okay, everybody, we're going to get started now. Welcome to the webinar. I'm Molly Robb, the project coordinator for the California Evidence-Based Clearinghouse for Child Welfare, or CEBC for short. I'd like to thank you all for joining us and welcome you to the webinar. Thank you for answering the poll questions. This is helpful information for our presenter. We've muted your phones due to the high number of participants attending. So if you're experiencing any technical difficulties or have any urgent questions, please use the Q&A pod located on the right side of the screen and we will do our best to assist you. We will also have a brief Q&A section halfway through the webinar. Please use the Q&A pod to send us your questions. Please also find the PDFs of the webinar PowerPoint slides at the top of the screen in front of you. Lastly, you will receive an email with a link shortly after the conclusion of this webinar to complete a short and easy survey so we can continue to improve our webinars and make them as useful and beneficial as possible in the future. Now, a brief introduction of our presenter. Joanne L. Davis is an Associate Professor of Clinical Psychology, Director of Undergraduate Studies in Psychology, and Executive Director in the University of Tulsa Institute of Trauma, Adversity, and Injustice at the University of Tulsa in Oklahoma. She is an associate editor of the Journal of Traumatic Stress. She received her doctorate from the University of Arkansas and completed an internship at the Medical University of South Carolina and a 2-year fellowship at the National Crime Victims Research and Treatment Center in Charleston, South Carolina. Her research interests include the assessment, treatment, and prevention of interpersonal violence and its effects. In recent years, she has focused on the assessment and treatment of chronic nightmares and other sleep disturbances. She has published over 60 journal articles and book chapters in the area of traumatic stress and has written a book on treating chronic nightmares. Without further ado, Joanne, take it away.
Thank you, everybody, for being here. I would like to thank the California Evidence-Based Clearinghouse for asking me to put together this information for you. It's been a process that has been going on for the past 2.5 years, culminating in this. I'd also like to thank one of my graduate students, Catherine Miller, who helped me put some of the information in the slides together. So for a group that's focused on child welfare, the first question some of you may be asking is why this topic? Why are we focusing here on adult treatments? Well, there's been an increasing awareness of trauma and its aftermath in the past 3 decades. And subsequently, there's been a burgeoning of available treatments, both pharmacological and psychological, to intervene with the negative impact that trauma often has. Today, we will be focusing on the psychological treatments, and we're going to be focusing mostly on the ones that have some empirical support behind them. The California Evidence-Based Clearinghouse Advisory Committee selected trauma treatments for adults as one of its topic areas in an effort to explore interventions developed to assist adults in coping with the effects that come from experiencing trauma. Many parents and caregivers involved in the child welfare system experience trauma themselves in their childhood or adolescence and have never received treatment related to these experiences. So these parents and caregivers, their trauma history can hinder the proper family functioning, social support, nurturing, and attachment. And research finds that more than half of all adults in the United States will have experienced a traumatic event at some point in their lives. And some estimates say that's closer to probably 75-80%. And though not all of the individuals will require formal intervention due to differences in resiliency or the ability to cope with traumatic situations, some may require treatment to mitigate negative outcomes. So as an advisory board, the CEBC hopes to better understand the impact of adult trauma, understand proper screening, and identification of the appropriate interventions that will lead to improved outcomes for both children and families. So the first thing to talk about is the definition of trauma. This is something that has changed pretty dramatically over time as each new diagnostic and statistical manual was introduced. And of course, last year we got a brand new one, DSM-5, so we have a new definition. So in the DSM-5, trauma is considered exposure to actual or threatened death, serious injury, or sexual violation in one or more of the following ways. And I have italicized their sexual violation because in the past uh, editions of the DSM, it was threat to physical integrity. And so one of the changes here is that they have clarified exactly what that means in terms of sexual violation. So this could be a direct experience or witnessing event, learning about the unexpected death, serious harm or threat of death or injury experienced by a family or close associate, and experiencing repeated or extreme exposure to aversive details of traumatic events. And so that now this includes things that may happen on the job for first responders, police officers, journalists. So of course we're talking about events such as natural disasters, sexual assault, motor vehicle accidents, and combat. Um, the new DSM also has changed the criteria for post-traumatic stress disorder a bit. It still has the intrusion symptoms, so the re-experiencing symptoms of nightmares or intrusive memories and images. It still has the avoidance symptoms, so behaviorally avoiding people, places, and things that remind you of the traumatic event. What's new is the inclusion of negative alterations in cognitions and mood. And this was added to the DSM-5 primarily because of the importance that research has found for the impact of the way we think about a trauma in terms of affecting how we respond to it. And then alterations in arousal and reactivity. There still has to be significant distress, impairment in functioning, and now you can specify whether the PTSD is accompanied by dissociative symptoms, depersonalization, or derealization. So in spite of the vast percentages of people who have experienced a trauma, we know that lifetime prevalence of PTSD in the United States is about 8.7%. 12-month prevalence of PTSD is about 3.5%. We also know that females experience less trauma overall, but are about twice as likely to develop post-traumatic stress disorder following a trauma. In terms of the course of PTSD, this is an example of symptom trajectory showing that many individuals will recover quite quickly, with most improvement occurring in the first 3 to 5 months. Some may recover quite slowly, and others have a chronic course of symptoms and don't recover without intervention. So about 30% of individuals will continue to meet criteria for post-traumatic stress disorder after about 10 years following the traumatic event. So the goal of treatment is really to shorten the duration of post-traumatic stress disorder. We are also going to talk today about a few interventions that have been designed to try to prevent post-traumatic stress disorder from occurring in the first place. So why the focus on adult treatments? There's been an increasing recognition of something that probably all of you have known all along in the work that you've been doing, in that you have to really look at the system. You can't look solely at the individuals. You have to think of kids in the family and the foster systems being cared for by people who themselves are likely to have experienced some type of a traumatic event and are suffering some consequences of that. And not addressing those issues at the adult level not only is negative for the adults involved, but will likely exacerbate the negative impact on the children and have an impact on their ability to recover from their own experiences. Many of us know about trauma and its effects. There remains many areas that are still significantly under-researched. One of these is the impact of trauma on parenting. And by this I mean the adult's trauma impacting the adult's ability to parent. Many of us in this room know very well that parenting can be extraordinarily challenging, even without the added distress and difficulties that accompany coping with a traumatic event, be it recent or past. There are a myriad of additional challenges when one is also trying to cope with a trauma. We know that 30 to 60% of maltreated children have caregivers who have experienced domestic violence. Included in these stats are parents and caretakers involved in the child welfare system. So they will have experienced not just domestic violence, but likely many other types of traumatic events as well, and may have never received treatment related to those experiences. So the history can hinder the family by increasing negative interactions, creating more irritability, less satisfaction. There have been a number of recent studies with veterans actually that have reported greater levels of post-traumatic stress disorder, specifically in the avoidance in the arousal clusters, can have an adverse effect on their own satisfaction with their parenting role. In 1984, Belsky came up with three different factors that he said affected parenting: contextual factors, ontogenic factors, and child factors. So contextual factors are those things such as work, your social network, marital relations. Ontogenic variables are the parent's own developmental history and personality, and then the child characteristics include the temperament of the child. So if the parent has a trauma history, you have to think about, okay, which of these areas are going to be affected and how. And what the little research that we have right now suggests is that all of these are affected. So in terms of the contextual variables, we see that adults with trauma history may have lower work productivity, missed days due to coping, physical and mental stress, may be higher if ongoing. They may have very few friends. Their marital relationships are likely to suffer. And there's a lot of need out there and very little support for them. Ontogenic variables, well, the trauma may have caused numerous problems and issues developmentally that may be still problematic. So if there was no intervention, things that happened early on can still be having an impact. And for the child growing up in a home with all of these issues going on, there are likely to be concerns related to parenting, especially if the child also has a trauma. We know that trauma is a relational event and has relational impact. It's going to have an impact on the parent's level of stress. It can have a tremendous impact on mental and physical health that create additional stressors for the parents. Individuals who have experienced trauma oftentimes have lower social support and high personal stress, resulting in higher levels of parenting stress. So they may struggle with stress tolerance and not have resources available to modulate their emotional responses to the daily stressors of parenting, much less if something else is going on, such as the child having a traumatic event themselves. There's been some conflicting information about the impact on parenting behaviors. There are some studies that find differences between parents with a trauma history and those without when you're looking at constructs such as warmth, use of physical aggression, effectiveness, while others have not found these differences. And these are likely related to the different methodologies used across studies, including some using self-report, some using observations. But there may be some interpersonal disruptions in parenting. We know that postpartum depression tends to be more significant for mothers who have a trauma history. Emotional numbing will affect the parent and child relationship and the ability of the parent to be responsive to the child. Trauma victims often have significant concerns with trust and safety. So our most fundamental beliefs about the safety of the world, about the nature of our relationship with other people, are shaken to the core oftentimes when we experience a traumatic event. And so this makes many people weary in regards to other relationships, even those with their own children. In times of high stress, they may not feel as if they can reach out to others for support, so they may not trust others to be there for them when they need them. In terms of intimacy, parents may feel afraid to get close to the children because they're afraid of damaging them due to the stressors that they're trying to cope with, or they may just not know how to feel close to the children. In terms of self-efficacy, oftentimes you'll hear about people not being able to trust or believe in their own ability to care for the child. They may blame themselves for their own abuse. And this awareness of or belief in failures as a parent may then even increase the burden of everyday parenting challenges. There's also some indication of overprotection and fear. So people have been through traumas may be consumed with concerns that this may happen to their own kids, and so they may respond by being very overprotective. Now, given all this, it is also extremely important to not over-pathologize someone because they have a trauma history, but rather to be aware of these possibilities in your practice so that you can do the proper assessment and then provide services if you find that the parent is indeed in need. And the point here is really to try to stop the cycle. So we know that there's likely an interaction effect with the parent's trauma symptoms exacerbating the child's symptoms following a trauma. So knowing about the appropriate treatments that can be administered to the parents can help not just the parents but the kids as well. So the California Evidence-Based Clearinghouse Advisory Committee hoped that better understanding of the impact of adult trauma and screening can lead to improved outcomes for children and families. And so when we started the review process, basically we were going to do a couple of different things. We needed to define the problem that we were going to work on, identify the available treatments, gather the information about the treatments, review that information, and then make a rating of the treatments. And I'm going to walk through each of these so that you know what we did and how we came up with the treatments we're going to talk about today. So the mission of the California Evidence-Based Clearinghouse for Child Welfare is to advance the effective implementation of evidence-based practices for children and their families involved with the child welfare system. And they have an amazing website that provides a searchable database of programs that can be utilized by professionals that serve children and family involved in the child welfare system. And the whole purpose of the website is to get information out there to the people on the front lines doing the practice so that they can know what the options are and what the evidence behind the different treatment options are. So the first thing that we needed to do was to define the problem. And the definition that we came up with includes this. So trauma treatment for adults are interventions developed to assist adults in coping with the effects that come from experiencing a trauma. The traumas may have occurred at any point in the individual's life and may have occurred once or many times. The traumas may be witnessed or experienced and can occur in many forms, including physical abuse, sexual abuse or assault, neglect, domestic violence, community violence, war, and natural disasters. Many parents and caregivers involved in the child welfare system experienced trauma themselves in their childhood or adolescence and have never received treatment related to those experiences. This parental caregiver trauma history can hinder proper family functioning, social support, nurturing, and attachment. Research finds that more than half of all adults in the United States will experience a traumatic event at some point in their lives. Though not all of these people will require formal interventions, some may require treatment to mitigate the negative outcomes. So this is how we laid out the problem that we wanted to address. Next thing, we had to identify the available treatments. So according to the CEBC, once the definition of the topic area is finalized, the topic expert will generate a list of potential programs for the topic area. The CEBC staff also conducts an extensive literature search at the same time to see what programs could be covered in the topic area. These lists are then combined and reviewed with the topic expert, and a final list is created. So only 15 treatments can be reviewed per topic area. I believe that the original compilation of lists from the CEBC and myself totaled around 35. So the next thing to do was to gather information to figure out which of these treatments could be reviewed. So this was our gathering information process. So we wanted to whittle down the list of possible treatments to review. There were screening questions sent out to the developers of the treatment to determine whether the treatment program had a manual or offered training, to establish the legitimacy of the context relationship to the program, to collect the program's goals, and to obtain their willingness to fill out a more detailed questionnaire about the program. The program questionnaire asked for the developers to include up to 10 peer-reviewed published or in-press studies, to provide references for descriptive articles or training manuals. The CEBC then conducted a literature review of the program, and the topic expert also conducted a literature review of the program. So in order to move on, the program must have either a written manual, offer formal training, or be able to provide some consultation. This is because the CEBC wants programs that can be implemented. So if people can't get information on how to do this, we did not want to include it. If a program is identified and passes the screening, but the main contributor does not respond or turn in the questionnaire, then the program might not be reviewed. The next step was to review all of the information. So all of the materials were then read by myself, the topic expert, and at least 2 other individuals. And then we provided a rating of the treatments based on the evidence that we gathered. So the topic expert and at least 2 others provided ratings, and these ratings were compared and the differences resolved if there were any. The reviews were then sent to the program for response, so they were able to read through what we had indicated and then to respond to them, and then the topic is posted. And this is an ongoing process, so this is not something that just stops with the information that we have now, but the program information is updated. So programs are asked to send new updated materials as they are published. Annual emails are sent out for new information, and all programs are reviewed every 2 years by the CEBC. So not only do you have access to this information on their website, but you will have up-to-date information as time goes on. So the rating scale that we used indicated the strength of the research evidence, so 1 being the strongest and 5 being the weakest, and NR was that we did not rate the program. And I will go through each of these as I talk about the different the different treatments. But at this time, I wanted, now that you know kind of why we're doing what we're doing and how we did it, I wanted to give a couple of minutes for questions at this point.
If you have any questions, please type them into the Q&A now. So Joanne, once you receive the questions, you can go ahead and just answer them out loud on the phone for everybody.
Okay, I'm sorry. For one of the questions was emotional abuse considered in terms of defining the trauma or the treatments that were chosen? Yes, we did. If the abuse met the criteria as indicated by the DSM for post-traumatic stress disorder. What you'll find as we go through the treatments is that most of them are appropriate for lots of different types of trauma. So there are very few that were developed and evaluated for just one specific type of traumatic event. So if you have somebody who experienced emotional abuse, the treatments, especially those with the scientific ratings of 1, should be able to be effective with that type of trauma. So the next question is, can you offer suggestions for screening tools that child welfare or social workers can use to ask caregivers about a past history of trauma? There are a number of available tools out there. Um, there is one called the Trauma Assessment for Adults. It was developed by researchers at the Medical University of South Carolina, and it is the one that I use. It goes through about 18 different types of traumatic events and asks about specific questions for each one to see if it meets the criteria for a DSM-defined traumatic event. Um, and there's also a much briefer version called the Life Events Checklist that's available, and that often is given with a PTSD screener. The next question is, were there any faith-based programs reviewed? Um, I don't believe that we had in our list of, definitely not in the list of 15, and I don't believe in the list of 35 that there were any faith-based programs available for review. The next question is, can you reference what role culture played, if any, in the research of the evidence-based treatments you will be discussing? Um, we looked at the evidence of the treatments in terms of the types of methodology that was used in the empirical studies, and part of that is where it was done and the samples that it was done on. And most of the research has been conducted in the United States. Excuse me. Um, we did find actually a treatment that has a scientific rating of 1 that has been done primarily with refugees in other countries across the world. But that's one of the only ones that I'm aware of that has been done with different cultural samples. I believe also that prolonged exposure, which we will talk about, has at least 1 randomized clinical trial that has been done outside of the United States. There is some very interesting work that's been done with cognitive processing therapy in, I believe it was Kenya, where they taught people how to do the treatment, and the people that they were teaching to do the training had maybe a middle school education. And it was really pretty fascinating what they were able to find in terms of the effectiveness of this approach with people who had very low levels of literacy and didn't have basic materials available to do the kinds of things that we would normally expect here in the United States. So for example, they didn't have paper and pens available to do their homework, and so they would have to figure out very interesting, creative ways to do that. At this point, I am going to move on and start talking about the treatments themselves, and I will come back to the questions that are coming in and try to answer those at the end. Okay, so for programs with a scientific rating of 1, they had to have a number of different indices. One is multiple site replication, so they had to be done by different researchers across different sites in at least 2 rigorous randomized clinical trials. In at least one of the randomized clinical trials, the practice had to be shown to have a sustained effect at least 1 year beyond the end of treatment as compared to a control group. So we were looking for long-term maintenance of treatment gains. They had to use reliable and valid outcome measures. If multiple outcome studies were conducted, the overall weight of the evidence had to support the benefit of the practice, and there had to be some available writings, some manuals or books, including trainings, so people could find out more information about them. So these were considered well supported. So this cartoon says, it feels like everyone in the world is lying to me. Congress is lying about the budget. Stock analysts are lying about the recommendations. My boss is lying. This therapy stuff is scientifically proven to work, right? And she says, yes, it's 100% perfect or effective. Well, not quite. Even for the highest rated treatments, they're not a panacea. They're not going to be effective for everyone or for every aspect of a problem, but they are the current best approaches that we have. And it was very exciting for me to see that there are a number of options at the highest levels of ratings. And there are a number of treatments that are at lower levels, but will probably make their way into the top ratings over the next few years as more research is conducted on them. So through our review, we came up with a list of four treatments that had met well-supported or a scientific rating of 1. These were cognitive processing therapy, prolonged exposure, narrative exposure therapy, and eye movement desensitization and reprocessing. I want to give you a bit of information about each one of these treatment approaches. So the first one is cognitive processing therapy. This treatment approach was originally developed in the early 1990s for survivors of sexual abuse. The original treatment includes both cognitive and exposure components. And I believe I saw from the poll that was conducted at the beginning of the meeting that there were a number of you who were already using cognitive processing therapy. So the basics about the treatment, there are 12 50-minute manualized structured sessions. The sessions are generally conducted once or twice weekly, and I think the developer really promotes doing the twice weekly sessions. The clients complete out-of-session practice assignments. It can be done in both group and individual formats. If it's done in a group, they recommend 12, 90 to 120-minute structured sessions, 2 clinicians, and 8 to 10 patients per group. So cognitive processing therapy is based on information processing and cognitive theory. The cognitive aspects include helping patients to recognize and experience emotions related to the traumatic event, as well as identifying and modifying disturbed cognitions related to beliefs about oneself, other people, and the world. And these may arise through assimilation, so changing information about the event to match pre-existing beliefs or schemas. It can happen through accommodation, which is where you change your beliefs to fit the event, or through over-accommodation, so altering belief structures to an extreme. These extreme beliefs then interfere with processing of natural emotions stemming from the event, such as sadness. The exposure component involves writing detailed accounts of the traumatic event and reading these accounts for homework and in session. This is thought to help to extinguish conditioned fear responses, allowing people to habituate to the fear related to the memory of the trauma. Again, the treatment is about 12 sessions long. Education and homework assignments target the identification and evaluation of the impact of trauma on those areas that are thought to be most affected by a traumatic event. So safety, trust, power, esteem, and intimacy. There have been dismantling trials that have looked at cognitive processing therapy without that exposure component, and I will be talking to you about some of the findings that they've had, and it includes homework assignments every week. In terms of the efficacy, controlled studies find that CPT is efficacious in reducing symptoms of PTSD, depression, guilt, and disruptions in social relationships. There is evidence of long-term maintenance. They have actually followed people out from between 5 to 10 years post-treatment and found that the effects of the therapy have been maintained. It has been evaluated in diverse populations. And in fact, I have military bolded up here because there is a veteran-specific manual that you can get from the developer, Dr. Risick. It has been used with interpersonal therapies, child sexual abuse, um, military sexual trauma. In terms of the dismantling studies, they've looked at cognitive processing therapy with and without the written exposure component. And they found that without it, they call that CPTC or cognitive processing therapy, cognitive. They found that people in that condition had greater improvement than in doing the written account, the full protocol. They have also done a number of studies looking at how long somebody needs to be in therapy. So the therapy was set up to be a 12-week or 12-session therapy, but they've looked at how many people actually need the full complement of the therapy. And they have found that um, most people, the vast majority of people, have reached good clinical outcomes at or prior to the 12 sessions. And so they're still looking at what might be the best way to structure therapy so that people are getting the dose that they need. So in conclusion, for CPT, it's an effective treatment, and there is some evidence that it may be treatment of choice for survivors who have guilt as their primary emotional response. And I'll tell you a little bit more about that in a moment. In terms of training opportunities, you can actually be trained for CPT online for free, and I have the website up there on the slide. And completing the online training is typically a prerequisite for attending the in-person workshops that are offered by the developer and her certified trainers. The next treatment is prolonged exposure. Um, the basics of prolonged exposure, this is an 8 to 15 weekly or semi-weekly treatment sessions that are about 60 to 90 minutes each. PE is manualized, and there is also an adolescent version available. You need to have digital voice recorders when you do this to audio record the treatment sessions, because that is part of the client's homework, is that they take the recordings home and they listen to them in between sessions. The theory behind prolonged exposure posits that there is a fear network that develops, which includes information related to the traumatic event and generalizes to information that's similar to that event in some way. This information may be similar to the trauma, then activates the fear network in people who have post-traumatic stress disorder. So therapy involves correcting the fear network so that people are no longer afraid of things that are not directly related to the trauma, that are not inherently dangerous. Clients are encouraged in prolonged exposure to repeatedly approach situations or activities that they are avoiding because they remind them of their trauma, either through in vivo exposure or through imaginal exposure, so revisiting the traumatic memory several times through retelling it. There is psychoeducation about common reactions to trauma, as well as breathing retraining exercises that are also included in the treatment. The aim of the in vivo and imaginal exposure is to help clients emotionally process those traumatic memories by going through those exposure techniques. They learn that they can safely remember the trauma and experience trauma reminders, that the distress that initially results from the confrontations with those reminders decrease over time, and that they are capable of tolerating that distress and no longer avoid it. In terms of outcome studies, there have been numerous controlled trials of PE suggesting that it's efficacious in reducing symptoms of PTSD and depression. It has been tested against a number of other approaches, including stress inoculation, cognitive processing therapy, and cognitive restructuring. Basically, what it found is that many of these treatments seem to work at reasonably the same level of effectiveness. Um, when you add components together, so for example, when they looked at prolonged exposure plus stress inoculation training, they found that it does not work better combining the two than either of the conditions alone. They have also found that with trying to combine prolonged exposure and components of cognitive processing therapy, that the additive approach did not work better than one or the other treatments alone. They also have found for prolonged exposure long-term maintenance, again following them 5 to 10 years, and it has been used with very diverse populations. In terms of training, there is online training available. There is also a manual for purchase, and training workshops are offered twice a year in Philadelphia, and I have the contact information listed there if you are interested in obtaining that training. The third of our well-supported therapies is called narrative exposure therapy. This therapy is listed as a non-responder because the developer didn't respond to requests from information from the CEBC, so the information that we have was gleaned from available resources. Narrative exposure therapy is a culturally universal intervention for the treatment of survivors of multiple and severe traumatic events such as organized violence, torture, war, rape, and child abuse. It attempts to reduce PTSD symptoms by habituating a patient to his or her emotional reactions to the lived traumatic event and by creating a coherent narrative of the person's experiences, their life experiences. So the therapists work with the patient to construct a detailed chronological narrative or biography. Over the course of 4 treatment sessions, the patient is asked to recall his or her life and include details of the traumatic event that they've experienced. Frequently, this narrative initially includes very fragmented reports of the traumatic event, and it's the job of the therapist and the patient to create a coherent narrative out of these reports. The process of construction also includes discussions to investigate current and past emotional, physiological, cognitive, and behavioral reactions to the narrative. The narrative is corrected during the course of treatment through multiple readings, and the process concludes when the patient shows evidence of habituation to the emotional reactions to the traumatic events, and then the patients receive a written biography at the end of treatment. There have been several randomized clinical trials that have been done with narrative exposure therapy, comparing it to psychoeducation, to trauma counseling, treatment as usual, and waitlist control. And what they have found is that it is better than no treatment and it is better than psychoeducation alone in terms of reducing symptoms of post-traumatic stress disorder and depression. There are some problems with the methodology included in these studies. Some of the studies had very small samples, and it's unclear how this treatment would work with other trauma populations, other than the ones that it has been specifically tested on. There is a manual that's available for purchase for narrative exposure therapy, but we were not able to find other information related to specific trainings for this approach. The last of the scientifically rated number 1 studies or treatments was eye movement desensitization and reprocessing, or EMDR. According to the descriptions of the therapy, adaptive information processing is the theory underlying this approach. This believes that information about the traumas may not be completely processed. This information is stored in memory networks that contain related emotions, sensations, and thoughts. And EMDR is thought to aid the processing of information through what is called dual attention stimulation. And as images become less salient, more adaptive information is attended to, and then that becomes incorporated into the memory networks. EMDR is an 8-phase psychotherapy treatment that was originally developed to alleviate symptoms of trauma. During the processing phases, the client attends to emotionally disturbing material in brief sequential doses that include the client's beliefs, emotions, body sensations associated with the traumatic event, while simultaneously focusing on some external stimulus. Therapist-directed bilateral eye movements are the most commonly used external stimulus, but a variety of other stimuli, including hand tapping and audio bilateral stimulation, have been used as well. In addition to PTSD, the authors of the treatment indicate that it is effective with phobias and other types of mental disorders as well, and there are no homework components. There are many common components related to other active PTSD treatments, so it has in common with them verbal exposure, imaginal exposure, positive imagery, cognitive restructuring, relaxation, and journaling. These are all common components of many different approaches to treating post-traumatic stress disorder. In terms of efficacy, there have been a number of controlled and uncontrolled trials evaluating its effectiveness. Some of these find equivocal findings. Some suggest that EMDR is more effective than other approaches. Some have found that EMDR is less effective than other approaches, in particular cognitive behavioral therapy. There have been several meta-analyses that have been conducted on EMDR. There was one by Davidson and Parker in 2001 that had a couple of important findings. One was that there seems to be little support for the role of eye movements or any other external stimulation in terms of being helpful in the treatment of trauma-related symptoms. There was one study in particular that found no differences between the protocols without the reprocessing component, so that cognitive component. There's little support for the necessity of training by the EMDR Institute itself. There have been a number of methodological limitations of the studies that have been done, particularly earlier on. But there seems to be some promise in using multiple brief interrupted exposures as opposed to a prolonged exposure process. In terms of maintenance, treatment gains have been found to be maintained for 18 months. So the treatment appears to be effective, but it may not be more effective than other forms of exposure, and there are continued questions about what is the mechanism of change. For EMDR training, there's manuals available. You can get a training certification, and I have the information listed there, including their website. So we have a number of treatment approaches that seem to be very effective. And so when you are faced with limited resources, you may not be able to afford to be trained in many different approaches for the same condition. So if you're going to spend resources on a training, it's important to make an informed decision about which one is going to be the most appropriate. Alternatively, if you are trained in multiple approaches, it's important to know what might work best with a particular client. So this therapy, or this research at this level into the therapies is really at its beginning. But I was able to glean a couple of things from the literature. The first thing to consider is the type of trauma that your client is presenting with. So narrative exposure therapy, for example, has only been evaluated with refugees, so it's unclear how it might work with people who are reporting other types of trauma. Other approaches have been evaluated with different types of traumatic events. And at this time, there does not appear to be any specific advantage for one approach over another based on trauma type. In terms of reducing PTSD symptoms, the approaches seem to be relatively equivalent. There is some evidence that cognitive processing therapy may be a better treatment choice for people who have significant guilt. In one study, it was found that CPT was better than prolonged exposure when it came to guilt. In terms of dissociation, they looked at cognitive processing therapy and cognitive processing therapy, just the cognitive components, and they found that they were equivalently reduced dissociative symptoms, but those individuals who started low in dissociation at pretreatment ended up doing better with the cognitive component, and those who were high in dissociation at the beginning ended up doing better with the written exposure component. In terms of refractory problems, there's been an increase in attention on the impact of sleep and nightmares on the development and maintenance of post-traumatic stress disorder. And the studies that have started to evaluate the impact of these first-line treatments specifically on sleep problems and nightmares find that that although they are helpful in reducing those problems, those symptoms remain refractory. So even after you've treated the PTSD, oftentimes sleep and nightmare issues will remain. For programs with a scientific rating of 2, they had to have at least one rigorous randomized controlled trial in usual care practice setting that found the practice to be superior to some appropriate comparison practice. They had to have sustained effects of at least 6 months beyond the end of treatment, use of reliable and valid outcome measures, and the overall weight of the evidence had to support the benefit of the practice, and it had to have some available writing, and these were considered supported. So we found 2 of the 15 that we reviewed for this project. One is cognitive behavioral therapy for acute stress disorder, and one was seeking safety for adults. Cognitive behavioral therapy for acute stress disorder is used in the early stages of the traumatic response, trying to prevent the development of post-traumatic stress disorder. And it is a typical CBT approach, utilizing education, relaxation, different types of exposure components, and cognitive restructuring. So the basic idea is to change the way that people are thinking about the traumatic event and alter the behaviors and the emotions in anxiety-provoking situations. There have been a few studies looking at the efficacy for acute CBT for acute stress disorder, and it find it to be effective in reducing intrusive avoidance and depressive symptoms compared to supportive counseling. So it seems to be helpful, but much more research is needed on this approach. Seeking Safety is an integrated treatment of post-traumatic stress disorder and substance abuse. It includes 25 different topics that can be conducted in any order, any length of time. You can mix and match and do them as you see fit for the people that you are working with. Has been conducted in groups of 2 to about 50 people. There's some equivocal results. Some suggested promising findings for decreasing substance abuse and symptoms of PTSD, but not all studies have found that. There are some studies that find that there is no difference with seeking safety when it's compared to other approaches. I also wanted to note for this that the VA has stated seeking safety is not to be used as a standalone treatment. In a report that they issued in 2010, it said seeking safety is not currently recommended by either the VA or the DoD for PTSD or substance use disorder clinical practice in their guidelines. So they're limiting the use of seeking safety as a standalone treatment, at least in the VA. For programs with a scientific rating of 3, at least one study utilizing some form of control had to establish the program's benefits over the control or find it to be comparable, again, reliable and valid outcome measures, and the weight of the evidence needed to support the practice. There had to be available writing. So these were promising. And as you can see on the slide, we found a number of different treatment approaches that have been considered to be promising. I'm not going to go through these, but they're there, and we have references available if anybody would want to look up more information on these approaches. And I have some information here on the slides. For programs with a scientific rating of 4, the treatment had to be shown to be at least equivalent to comparison, and the weight of the evidence had to outweigh or had to suggest that it failed to demonstrate an effect. We did not have any of the 15 treatment programs that we've reviewed in this category. None of them met that criteria. And that's not to say that there aren't studies out there that fail to demonstrate effect. It's just that they were not part of the 15 that we reviewed. And again, with programs with a scientific rating of 5, these were concerning practices. And again, I think that those are definitely out there, but they were not part of the 15 that were reviewed for the current review cycle. And so at this point, and we also found a number of programs that were not rated, not able to be rated because they didn't meet enough of the criteria for us to look at. And I have them listed there, and that may change as we go forward. At this point, we are running out of time, and I wanted to get to some of the questions that have been asked. So one of them is, Lately, I've been working with a lot of adults that have suffered from head trauma and that now have mental issues due to the trauma. Are there specific programs to help people that have suffered from head trauma? Um, there are programs that have been developed for traumatic brain injury, and they are just, and I believe you can find them on the um, National PTSD website. Um, there there are research studies that are just beginning to look at these first-line treatments, some of them, and whether or not they are able to be used with people who have TBI. I actually attended a training recently on cognitive processing therapy, and the developer was talking about some successes with people who have had mild to moderate TBI, and that they were able to use cognitive processing therapy um, with those individuals. Another question is, we are looking for appropriate brief screening tools for adults and children for use in primary care practice by medical professionals. These are people with no training in the mental health field. If trauma was found, the patient would be referred. Can you advise on the appropriate screening tools? Actually, I'm going to refer you again to the National Center for PTSD website. They do have a very brief screening tool just for that purpose. So it is available, and I can make those links available to CEBC when the webinar is completed. But they do have, I think it's a 3 or 4 question screener that physicians can use. And the point is to identify people who may have traumas, who may have issues in this area, and then be able to refer them on to services. And it looks like that is all the questions that we have at this time. I want to thank you very much for attending the webinar, and I will pass it back over to Molly.
Thank you so much, Joanne. Just a reminder to everyone, you will be receiving a link to a survey on this webinar via email within the next couple of days. And the recording of this webinar